The fourth and current wave of the COVID-19 pandemic has created a worrisome landscape for the nursing profession. Nurses across the country report they no longer feel celebrated as heroes as they did in the early days of the pandemic. Hostile patients, vaccine distrust, staffing shortages, and community indifference have been on the rise, making the job of treating and containing the coronavirus even more difficult. How can hospitals and health systems best support their nurses? What are some ways to reduce stress for frontline workers? And what can be learned from the current pandemic climate to help strengthen and fortify the profession moving forward? Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Petterly with AHA Communications. In this podcast, the American Organization for Nursing Leadership and the Health Research and Education Trust are brought together by the AHA's Living Learning Network. That's a CDC-funded, peer-to-peer community of healthcare professionals dedicated to helping hospitals and health systems recover, rebuild, and reimagine the future of care. AHA Senior Communications Manager Ben Wise is joined by Patricia Quinn, a registered nurse and board-certified nurse executive serving as Director of Maternal Child Health, as well as the nurse manager of neonatal ICU and pediatrics at Lenox Hill Hospital and Northwell Health, and also AHA board member Mary Beth Kingston, PhD, Chief Nursing Officer at Advocate Aurora Health, and an American Academy of Nursing Fellow, to discuss the current landscape of the nursing profession.
Mary Beth, Patricia, thank you for being here today to discuss this worthy yet worrisome topic. Before we dig into the issue at hand, I was hoping we could get to know you each a little better. Patricia, please tell me a little bit about your role at Northwell Health and the path that you took there.
Absolutely. So I am the current Assistant Director of Nursing for Maternal Child Health at Lenox Hill Hospital and the nurse manager of the neonatal ICU and pediatric unit. I started here right out of nursing school in the neonatal ICU, and I always knew that I wanted to be a pediatric nurse. I was 10 years old. My sister was born with Down syndrome and a full AV canal that needed to be repaired when she was about 3 months old. So spent a lot of time around nurses and really incorporating our family into the care of my sister and kind of just saw that as my career. So went into that and then became a neonatal ICU nurse here and fell in love with neonates and with brand new families and really getting babies to be well enough to go home with their families, and became the assistant nurse manager of the same unit about 2.5 years later. And then 2.5 years after that, became the nurse manager, and this February became the assistant director of the entire division. So have really moved throughout my career here. And then during the pandemic, was asked to actually leave the neonatal ICU and manage one of our pop-up medical ICUs for COVID with non-invasive care, and learned a lot in that experience and really grew a lot in my career. So it definitely was a huge adjunctive to my leadership path in nursing.
What a wonderful story. Thank you. Mary Beth, please tell us what a chief nursing officer does and how you came to the field of nursing.
Well, chief nursing officer role is there's some similarities everywhere, but there are some differences. But I'll start with how I came to be a nurse. I was in a car accident as a young teenager, and I was as tall as I am now, which is 5'6", and I was on a pediatric in a ward at the time with 2-year-olds and 4-year-olds, and the nurses kind of let me help, which is, and again I'll say is in quotes, and I was really impressed with the work that nurses do, both in the caring and then even at that young age, I could see the science behind the work that they've done. So that started me on the path in nursing. I've been a CNO in many different settings, community settings, academic medical settings, both at one hospital and then also in a system role. CNOs are essentially responsible for nursing care standards and the subsequent patient outcomes, with a major focus on strengthening the workforce, supporting nurses so that they can give the care that our patients need. Never more important than it is now. My role as a system CNO is a little bit less operational than it was when I was managing a specific site or hospital. It's very much across the continuum. So it involves home care and practice in the ambulatory settings as well. all CNOs, wherever they are at, are really essential members of an organization's leadership team, and they bring that nursing voice to decision making. Never was this more evident than during the pandemic, and I had the opportunity to co-lead our clinical incident response with our chief medical officer, and other nurses had major leadership roles throughout our system.
Thank you. I appreciate that perspective. And I guess on this topic of strengthening and supporting nurses in the time of COVID, let's turn to the matter at hand. On August 23rd, the New York Times published the article, Nursing is in Crisis, Staff Shortages Put Patients at Risk. In it, frontline workers discussed a troubling landscape facing the nursing industry. From labor shortages to lack of emotional support, nurses across the country report that they no longer feel like the essential worker heroes from the early days of COVID-19 pandemic, which has now affected over 44 million Americans. Mary Beth, what are your observations on the current climate in the nursing profession?
Oh, there's so many. Where do I start? Let me start by saying that, some of that perception is absolutely true. Nurses are very tired. This has been going on for a very, very long time. The polarization that we see in our society right now is also seen in healthcare. And so while the community support is there, it's not nearly as visible as we've seen in the past. We are seeing things such as individuals and family members that don't support measures that prevent transmission of COVID. So specifically not wanting to mask or being very much opposed to vaccination efforts. And this has caused tremendous tension throughout healthcare. It's caused tension within our own nursing ranks and with our own team members, with individuals, particularly with vaccine, having different opinions on that. In addition, we are caring for some folks who don't believe that COVID is real. And that has made it very difficult, I think, for nurses providing care, particularly at the end of life when someone does have a COVID diagnosis. That shared understanding that you would typically have with the family and with the patient is not there. And again, that creates significant stress. So there are many, many challenges today, and staffing is one of the other issues that we can talk about in more detail. But for a variety of reasons, we are seeing more nurses leave their roles. And at this point, we're not seeing fewer enter, but we are keeping our eye on that. But nurses are feeling the stress and strain of this prolonged pandemic.
Thank you for sharing that. Patricia, I know there's probably a lot of things in there that you can relate to, but I'd love to hear your thoughts on this idea of feeling support. And I wonder also if you've experienced specific issues with people not wanting to mask or vaccine hesitancy.
I think the support piece is double-edged sword. In the beginning of the pandemic, especially in New York City when we had the first wave, there was such tremendous support. And we also didn't know a lot about COVID. The community really rallied around not only nursing, but healthcare providers in general with what we called the 7 p.m. clappy hour and bringing food in and writing like amazing letters and kids in virtual schools filling out coloring things, and everything was kind of blasted on the walls. And you felt a lot of support as a healthcare worker, and you really felt like what you were doing mattered. Not that you don't feel that already, but that the community really understood your role. And I think as COVID has continued, part of it is this juxtaposition that we are seeing with people that believe in COVID and people that don't, and masking, but also just people being tired. And then also people returning to work. So the rallying around just the healthcare profession very much happened because people were, we were on pause, and a lot of people were not at work and were not at school and had other availability of their time and really utilized that to support us who were going to work every day. But now a lot of people are back at work and the kids are back at school, and people are kind of like, when is this going to be over? So that tired feeling of the fact that this pandemic is lasting so long, along with the unfortunate political divide that we've seen, that it's become very politicized instead of really just scientific and following the medicine and the knowledge. And then having those people come into the facility and kind of struggling with that. I have an example actually just from today. We have a patient come in who we test all of our patients upon admission. She tested positive. She was asymptomatic. She was vaccinated. Her husband was vaccinated, but he unfortunately did get a variant of COVID as well about a week ago. And they were here to have their child. And they were both asymptomatic. We had them both here. And after delivery, mom spiked a fever, which may or may not be related to labor or to her new diagnosis of COVID. And our protocol and policy really is to separate the newborn from a symptomatic mother, especially during that initial period where we feel like the viral load is high and the risk of transmission to the newborn is high. This family very adamantly did not want that to occur. And so it just creates a lot of tension between giving the best care and wanting the family unit to stay together and be successful in breastfeeding and bonding, but then also wanting to do what's safe for the newborn and for, the staff in terms of the amount of exposure that they have, asking the father to leave. And he adamantly does not want to leave his wife and his newborn child, but really looking at there are now nurses and doctors and nursing assistants and respiratory therapists that have to go in and interact with that family and are more at risk now that the father is refusing to leave, that there's a second person that is positive in the room. The way that I look at it is trying to look at each situation and have a little empathy. I mean, imagine being in a pandemic and not being able to stay with your newborn and you're having your first baby and someone telling you your husband can't be there, you're going to be all alone and you're not going to have your baby. And what does that feel like? And also being as a leader, being able to support the staff in the fact that they're like, we also don't want to be more exposed than we need to be. And, obviously we have PPE and we have precautions, but if there are ways to diminish their exposure, how do you support the staff in doing that as well? I don't think so much that everything is so black and white of COVID is not real, COVID is real, or I don't believe in masks or I do believe in masks. I think there's a lot in the gray area, but I think everyone is trying to look out for themselves and to protect themselves. And how do you in healthcare kind of manage protecting our staff and providing the best care for our patients?
That's a very poignant example, and thank you for sharing that. And it's so interesting to think about the ramifications of these actions and how it affects all of the frontline workers. Mary Beth, I'm interested in your reaction to what Patricia was saying, but also curious as to what you're hearing on the executive level regarding nurse burnout, fatigue, and such.
As I mentioned, we certainly are seeing burnout and fatigue, and some of that is resulting in nurses, either those that are near retirement, deciding to move, those that just are tired, needing a break, leaving the work setting. We're also seeing, and I'd be interested to see if Patricia's hearing this as well, many nurses leaving for travel agencies. Due to the shortages, the rates have risen, and so there are folks who really enjoy the work setting they're in, but have the opportunity to really increase their salary, 3 times, 4 times. I mean, that the dollars are pretty extensive that are there. So we are hearing and we're seeing that. Compensation is an important strategy for us, typically short term if people are tired, but working to provide incentives for our own team members, our own nurses is extremely important. Providing support, and I think you'll see across the country, most organizations have a variety of programs. But what we find with nursing is going to a program for support, having to leave your unit or come in on your day off is not something that typically appeals to nurses, particularly when they are feeling that stress. And what we're doing is trying to focus on the team and the unit. We have a peer support program in my organization called Together as One, where physicians, nurses, leaders, others, anyone can really apply to be in this program. And these individuals have more extensive training, and they have a badge that identifies them as being a peer support person. And so someone, while they're working, can come up and talk with them. They can help them and kind of direct them to the appropriate resources. We've provided Zen-dens or quiet areas for respite. I think these are some strategies bringing support to nurses where they work that are really going to be successful. We have to look at what's important right now at our work as well. One thing we've done is we've just taken a broad look at all the initiatives. And if you've ever worked in healthcare, we have a lot of initiatives that occur. What can we stop doing during this time that is not essential? We often ask for champions on every single unit. Maybe this is not the time to use that approach. What type of documentation is essential, and how do we work with our teams to implement that? And then, of course, we're supplementing staff. Again, in my organization, we have just done a reach out again. Many of the things we did during COVID, but it's a little bit different because when the COVID pandemic first started, we stopped doing a number of procedures and offering services. So we had team members and staff that could help. We're still doing, really keeping most of our services going right now. But we are looking at folks that work maybe in the corporate and other areas that can help with some specific things, such as transporting patients or working in a sitter role after some training. And that really, I think, demonstrates to nurses that people are hearing them and are willing to step up to help. And then lastly, I just was rounding some of our sites last week, and some of the feedback I did receive from our nursing staff was that not just the discussions about masks and vaccines, but that incivility and workplace aggression and violence are also increasing. We've got to take a good, hard look at that workplace and see what we can do to make it safer for nurses and more supportive for nurses.
So appreciate that point of view. And Patricia, I'm curious to get your thoughts on this. Mary Beth mentioned as ways to address these issues as focusing on the team. And I know you mentioned ways of increasing empathy in your own work. So what strategies do you have, you and your team have for combating fatigue and burnout or even just scheduling headaches?
Yeah. We are seeing, like Mary Beth was talking about, the difficulty with travel assignments and people that are working in the field that they love but can make a significant amount more if they were to take a travel assignment. And that kind of just makes it more difficult to staff the unit because we really can't compete from a hospital system level in terms of the financial incentive with that. So, what are ways that we can really focus on the team and really keep people together? And I think Mary Beth made great points that a lot of it really needs to be when the team members are here and not asking them to come in off their shift or to utilize resources when they're not working or to go to an hour meeting and have to hand off their patients to someone else. So we have a team in Northwell called Team Lavender or Code Lavender. It's pretty well known throughout the Northeast at least. And the nurses and other staff in the unit can call the operator and call a code lavender just like they would call any other code. And that activates a silent team that we have that has members of pastoral care, members of our HR team, members from our psychiatric department, and then volunteer nurses and physicians that will come to the unit and do just in time kind of crisis counseling with the staff depending on the situation. And they bring in stress balls and bags of lavender and kind of lavender scents, and then also the system resources like our employee assistance program and how to reach out for counseling if that's something that they're looking into, and really bringing those resources to the staff instead of having them have to really search for it and really pushing in. We also have a peer support program, and our program is a push-in model. So the leaders identify that there was a situation on the unit and certain staff members have been affected, or if there's something going on with a staff member at home, and a peer supporter actually pushes in and reaches out to that staff member and says, hey, we heard this was going on. We want you to know that we're here and we can talk through this with you, instead of the staff member having to reach out for the help. And many times the staff member doesn't necessarily accept that help, but at least they know that it is there and it's not them feeling like they're not supported. So kind of utilizing that. We also have what's called a lavender lounge where the staff can go during their breaks and just have a quiet space that's just for staff and kind of be with their thoughts and have music, and the resources are there as well for them during that. And then really focusing on health and wellness, because I think that's really a big portion that gets lost when you're high stress and tired. So we right now are walking the Caribbean. We're doing a virtual walk. Teams of 6 throughout our health system are competing against each other. My team just got to Haiti this week. We're on our way to the Dominican Republic. And at the end of the virtual walk, Everyone who makes it to the final destination, which we're not sure where that is yet, but it's somewhere in the Caribbean, will be entered into a raffle to win a trip to the Caribbean. So just a little friendly competition and, being able to get your steps in and, increase your activity a little bit while doing something that's fun to promote that with an incentive.
Well, that's wonderful. And it's so great to hear about things like Team Lavender or Together as One as ways of you and your colleagues coming together and addressing these issues. I do want to be mindful of the time, but before we have to sign off, I was wondering if there's anything else that you think the public should know about the current state of nurses and possible solutions moving forward. Patricia, let's stick with you. What are your thoughts on that, please?
I think there's so much. I think nurses just really want to be people to remember that we're still here, that we're still going to work every day, that we're still caring for patients. And sometimes that means caring for patients that don't believe in COVID, don't believe in vaccination, don't believe in mask mandates, but we will continue, just like we have through many other political things. We will continue to care for them regardless of what their views are because it's important and because patients are important. And I think, I remind people all the time to thank a nurse, to call a nurse. If you have a nurse in your family, just take a minute today to send them a text that you appreciate them, that that they're still going through this and that it's still hard. And not only nurses, but other healthcare workers and teachers. I think the camaraderie that I saw between nurses and teachers when the teachers initially went back to school was tremendous, profession to profession, saying, we've been through this and we were scared and we know this is just the start for you and it's scary, but you'll get through it just like we did. So just being aware and being able to do little things. I think in the beginning there were these big things, and I think now we just need to focus on the little things and the simple text message, the phone call, the card to someone's house, the cup of coffee, just the little things to let nursing and healthcare workers know that we know you're still working really hard and we don't necessarily have a fast solution for it, but you're still there and we still appreciate you.
Thank you. Mary Beth, it looks like the final word is yours. What should the public know about the current state of healthcare, especially care providers?
Yeah, and I think Patricia said it well. That nurses really enter this field to make a difference. They're committed, they're educated, they're capable, but we have to remember they're also human and they're not immune to the stress. And they face all the issues that everyone else dealing with the pandemic faces, in addition to providing care in this current environment. I think it's important for us to remember that it remains a profession with just exceptional opportunities for growth and for satisfaction. But as a society, we need to support and value the contributions of nurses in nursing. I mean, when people say that nurses are the backbone of healthcare, they are virtually in every healthcare setting. And I think we know now more than ever that nurses are essential to our ability to provide care.
Mary Beth Kingston, Patricia Quinn, thank you so much for this engaging conversation and all the work that you're doing. I also want to thank the American Organization for Nursing Leadership and the Health Research and Education Trust for their help and guidance on this topic, as well as our partners at the Centers for Disease Control and Prevention for their support of the AHA Living Learning Network. You can learn more about the network at livinglearningnetwork.org.
The views and opinions expressed here do not necessarily reflect the official policy or position of the CDC. The involvement of the CDC should not be viewed as an endorsement of any entity or individual involved.